afterwards. And then please use the chat box if you want to raise any questions, but we also have a Q&A at the end of all the speakers, so to give you plenty of time to ask any other questions or discussions. I hope you've grabbed yourself a drink, and I would say just also enjoy the webinar, and I hope you will pick up loads of things about it, and feel free to tweet. And if you can include at Agile CSP or at CSP BAME, that'd be great. And then, oh, I don't know, I'll try to get to the next slide, but no, I can't. Okay, so I was hoping to share the next slide, but it just somehow it's not happening. So the agenda for today, so we've got 3 speakers, and they will all talk about different aspects of health inequalities in the older person's healthcare. The first speaker will be Arnie Prentice, who is the Research and Policy Manager at the Race and Health Observatory, and she will talk about the overview of ethnic health inequalities and work of the RHO, including research. This will be followed by Wendy Thorne, who is a physio in the older persons rehab, but also a lecturer at the St George's University in London. And she will very much talk about health inequalities with students, education, and in clinical practice. And then at last, but not least, it will be Banu Ramswamy, who is an independent physio consultant based in Sheffield. And she's also an honorary visiting fellow at Sheffield Hallam University. And she will talk about the clinical implications using examples of Parkinson. And then following all the speakers, this will be followed by the question and answers. And I just say, I hope you enjoy the evening, and then I will hand you over to Arnie. Thank you.
Lovely. Thank you so much for inviting me to come and speak. I have to apologise. I've got a cold and sound horrendous, so I do apologise. And I might have to mute and cough and then come back again. But right, let me try and share my screen. Wait for it to load up. Can you see just the slide, or can you see the next slide as well?
We can see the next slide as well again, Arnie.
Okay, that's fine. Let me swap. Can you see just the main slide? Fantastic, thank you. Okay, so my name's Arnie Prentice. I am a physiotherapist and have been working clinically for about 20 years, and before I came into this role. And so I was previously I was a clinical team lead in sort of frailty and complexity in older adults in the community in London. And then I moved into this role at the Race and Health Observatory as a research and policy manager. And so what I'm going to do today is just talk a little bit about health inequalities from my perspective as a person who works at the Race and Health Observatory, but also as clinicians kind of out there listening and researchers out there thinking about the kind of clinical implications and actually what I saw day to day when I was practicing physiotherapy. So ethnic health inequalities. So this is a really nice infographic that we designed at the RHO that kind of talks about the different inequalities that we see. And so health inequalities are avoidable, they're unfair, and it's a systematic differences in health between people from different ethnicities. So what we can see from here, and this is some stuff that is well known by the media, for example, the kind of work around maternity is really well publicised, the fact that Black women are 4 times more likely to die than white people during pregnancy and childbirth. But some of the lesser sort of publicised statistics are around sort of blood donors, like you can see on there, or also in terms of mental health, the kind of number of people from Black African and Black Caribbean people being more likely to be sectioned on a community treatment or disorders than white people. We've got differences in terms of organ donation, differences that we see with learning disabilities and cardiac heart disease, and all of these differences that we see, they're not due to broken bodies. They're not due to differences that we have that are caused by our cultures or by our ethnicity or by our perceived race. In terms of, it's not us and our bodies that is a problem, but there's things that are out there that are causing these inequalities. So in that sort of definition that I gave, they're avoidable, so they shouldn't be happening. They're unfair, so they're not just. And it's systematic things that are happening that are causing these. So therefore, they are all changeable. So at the Race and Health Observatory, the reason we were set up was to reduce these ethnic health inequalities and to act as a critical friend. So we are a relatively new organisation. We're only set up 3 years ago, and it's a really small organisation. There are actually only 10 of us in the whole team. And these are the kind of 3 areas that we work on. So the first is kind of making sure that we have evidence to make sure that everything that we're doing is actually evidence-based and we're making sound recommendations. So if the evidence is already out there, we can work to synthesize to bring it together. If it isn't out there, we can start to commission it. We then use that evidence to influence, so to work with leaders to provide practical recommendations, to change policies, to change clinical guidelines. And then the third thing is implementation. So actually, how do we put those recommendations into practice? What kind of tools or support does the system need in order to kind of deliver the recommendations that we're giving? So in terms of our impact, so this is kind of how we work. So we have insights and evidence. So like I said, identifying those gaps. The other thing that we do when we're commissioning research is thinking about how do we reduce the inequalities that exist within commissioning and within research. So within our tenders that we put out, we always kind of say, what are your links with the community? What have you published previously? Who do you work with, and what kind of EDI strategies, policies do you have in place within your organization? So what we don't want to do is keep sort of recruiting people that have already done the research, because then what we know within academia is that there is inequalities within that. There are very few Black professors in the country, very few, very limited ethnic diversity within academia as a whole. So what we try to do is make sure that the people that we're giving money to and commissioning are people that actually know the work, are going to be good at the work, and are sort of upskilling people as well at the same time. So like I said, we use the information that we have to kind of drive that policy change to make sure that things are actually happening at a higher level. And also speaking to leaders, so speaking to CEOs, speaking to the ICB leads, and trying to get people kind of to understand why we have these health inequalities and what we can do to change it. As part of us as an organisation, we try to engage with the public to try and understand what they want from us as an organisation. And today we're having a conversation around that sort of community engagement, and how do we do that, and how do we make sure that whatever we're researching, whatever recommendations we put out, that actually impacts on an individual. So one of the big research studies that was done during COVID was one looking at pulse oximetry. And you probably saw it in the news during COVID, and then it came back around again in the news this time to say, yep, they've said that they're not fit for purpose because the pulse oximeters that are used are inaccurate for people with darker skin tones. But as a person with a darker skin tone, hearing that information, how does that then impact me? What will I then do differently? Or how can I then advocate for myself when I go into hospital, or when I go into hospital with a loved one and they're just using that pulse oximetry reading as a diagnostic tool? And so it's enabling people to be able to say, well, actually, there was this research that was done, and what other clinical signs are you looking for? So rather than just making sure that the research gets out there, it's making sure that it's impactful and actually has real world impact. That's what we're looking for. So that's sort of creating practical tools for the system. So making sure that people have got things that they can do on the ground, rather than just knowing these inequalities exist and not really sure about what to do about them. So as an organisation, at the beginning of our sort of journey, we were very focused on that research element. And then more recently, now we're moving into the implementation of actually, how do we do this? So there's some exciting projects that are happening at the moment, looking at anti-racism QI methodology, so quality improvement and service improvement, which I'm sure lots of you have done in your clinical practice, but looking at it through an anti-racism lens. So acknowledging and identifying that racism exists. So when I worked clinically as a physiotherapist, we used to run falls classes, and we're in a really diverse part of London. But actually, when we looked at who was coming to the classes, it wasn't the population of the borough we were serving. It was a white middle class woman. And lots of you work within falls, I'm sure, and you know that that isn't the only people that are falling. But our classes were designed in such a way that they were only really accessing that population. So looking at it from an anti-racist model would be able to kind of acknowledge, okay, this isn't right. Why has this happened? How do we make this different? And if we just accept that we need to be anti-racist, then what we set up in our service will be completely different, rather than it being designed for the people that we think would like to come, because that's how we look and what we think. We'd actually be going out into the community and asking people, okay, what would you like it to look like? Where would you like the service to be run? How could we make this more appropriate for you? Where, you know, what time of the day could it be at? What community setting could it be at? And we just look at things in a very different way. So that's a piece of work we're doing. And at the moment, we're looking at maternity and neonatal, because that's our sort of one of our largest work streams. But the principles of that will then be things that then can be used, of course, in other areas. So some of the work that we've started to look at specifically around older adults is with regards to dementia. So some of these stats are quite shocking, really. And so we know that dementia, you know that we have an aging population. You know, as people that are part of Agile, we kind of know that. But these are some of the stats around actually Black and South Asian people are more likely to be diagnosed at a younger age and die earlier of dementia than white people. I don't know whether these are new stats to you guys, whether you've heard them before, but you know, that's quite shocking that they're diagnosed younger and they're dying earlier. So their life course is much shorter, and they're from Black and South Asian backgrounds compared to white people. And like I said, that's not due to a genetic issue. And then we look at that next statistic where it says dementia incidence is over 20% higher amongst Black adults compared to the UK average. So that's a really high difference. And then this stat was kind of quite shocking as well. So when we look at the kind of who has dementia, we're looking at the aging population. The amount is going to increase from people from BME, from Black, Asian, minority ethnic backgrounds, is going to be much steeper than it is for the white population. And it says that the steepest increase is expected in the South Asian community. And there's another stat that I found that said by 2051, the number of people living with dementia will have doubled for the white population. But for Black and ethnic minority people, it would have increased by 7 times the amount. So that's huge. And if you think about that and the enormity of that, we need to make sure that our services and our clinical practice is geared up for that. So when, you know, there's lots of information out there and lots of people that say they've experienced racism from their healthcare providers, from society, but as a society, we're frequently, as you know, society and white people kind of, and nobody, in fact, thinks that they're racist, but everybody has experienced racism if you're from a Black or brown background. So it's about, okay, well, if we know that this population is going to have a higher population of people with dementia from these backgrounds, how are we going to make sure that we're treating them effectively and fairly and equitably? I don't know if equitably is a word or not. But the other thing, I don't have a slide for it, I wanted to just touch on research. And actually, I kind of talked about it in terms of the academic perspective of the researchers and how sort of skewed that is. But also when we're looking at conducting research, the participants that we have are predominantly white men who speak English. But actually, when we're conducting research, if we want to be better at looking after and serving the communities that are diverse, we need to make sure that we're getting those people represented in our research cohorts. So how do you go about doing that? How do you make sure that you've got that sort of true co-production within the system? And part of it starts by having the right people doing the research in the first place. but also it's about asking those questions, and NIHR are doing quite a lot of work around that, and we're linking up with them to advise them on how they could be doing that better and how they can advise researchers. Sorry, the other bit I meant to say about dementia, you can tell I've got a cold, I'm sort of just going back and forth all over the place, but the piece of work around dementia that the RHO are doing is looking at what's currently happening out in practice, and what work is happening that is culturally sensitive and is improving access, experience and outcomes within dementia services for Black and Asian and ethnic minority people. So that piece of work will be going out to tender probably, where are we? We're in March. I think in either April or May it will be going out, which will be a really exciting piece of work where we're going to be getting research to kind of look at that and then be able to have guidance around, okay, this is what culturally appropriate services could look like. This is what we recommend you do. And also as part of the work, they'll be going all over the country to kind of find out what's already happening, what is good practice. So if you know that in your area you've got some good practice, then please get in touch so that we can then share that with the researchers once that's commissioned. I think I'm now handing over to Banu to talk about her clinical work. But if there are any questions, please feel free to add them in the chat and then we can have a discussion. And oh no, I'm not handing on to Banu, I lie, I'm handing on to Wendy. Wendy, I'm sorry. So I'm going to hand over to Wendy, who is a wonderful, wonderful colleague that I used to work with. And she will talk to you all about her fantastic work. Yeah, and any questions, pop them in the chat. I'm going to stop sharing if I can. There we go.
Okay, thank you, Arnie. So my name is Wendy Vaughan. I am a physiotherapist. I've been working in older persons rehab for 12 years now. And for the past 5 years, I've been working as a lecturer part-time at St George's University in London. So I've been asked to come and give you a quick 10-minute talk about health inequalities. And so what I want to do today is, firstly, let me apologise. I do not have any beautiful slides like Arnie's had, so you've just got my face, but hopefully that will do. So what I want to touch on today is just about health inequalities, what it looks like in education, how students and qualified staff and people working in healthcare understand, and also what it looks like in practice. So the lecturer in me always wants to start with a definition, so we're going to start with the definition. So health inequalities, so they are unfair and avoidable differences in health across the population and between different groups within society. But it also refers to the difference in care that people receive and the opportunities they have to lead healthy lives. So when we think about health inequalities, we think about the drivers. So things like economic stability, education, social cultural factors, and the environment. So essentially what we're saying is where you are born, where you live, where you work and where you age, all of these impact on your access to health or health inequalities. But we also consider modifiable factors, so such as nutrition and lifestyle. So we teach all of this as part of the curriculum at the university where I work, and I'm sure across many universities. And what we do is we teach it in the context of bias and privilege. And so we give students scenarios and we get them to kind of challenge their own biases, try and work out where the health inequality is happening and why it's happening. And while it looks really great on paper, I was really, really curious to know what it would look like to the students. What did they understand about it? What do we as healthcare practitioners understand about it? So just quickly touching on the coin model. So Cynthia Nixon, who talks about the coin model and talks about privilege and who sits on top of the coin model and who sits at the bottom. And in one of her talks, she says that those people that are on the bottom of the coin model, because they're experiencing maybe some bias, discrimination or inequality, truly understand that because obviously it's a lived experience, but those that sit on the top really have no idea. So with that in mind, I thought, let me just speak to a few students and let me speak to some colleagues and just see actually how does it land with them. So I'm going to share with you some of the conversations that I had. So I had some real just casual open conversations with students. And I just started off by asking them, what does health inequality mean to them? So one of the responses was, and I'm gonna have to start reading these now because I can't remember them all in my head. But one person said to me, it's about money. So if you can pay to go private, you don't have to wait. But it has nothing to do with race and it has nothing to do with religion because I haven't experienced it. And so for me, that also goes to show that if you don't experience something, it's quite easy to feel that it doesn't exist or really not to notice it. Another person said, well, it doesn't really affect me because I've got it a little bit easier because my skin tone is a bit lighter. However, it's not as bad now as it was back then. This is someone who is, I think he's 27 actually. And so my question was, how do you know how bad it was back then? Well, it doesn't affect me, so it can't be as bad. So I then went on to ask, in relation to the teaching that they have, do they feel that they are equipped to identify when health inequalities are happening? Responses range from teaching is very adequate, we've got strategies to implement, and some people felt that it was too wishy-washy. It promoted free thinking, and that wasn't what was needed in a healthcare setting. It needed to be more didactic. So very interesting. These were students that I was talking to. And now, as part of their assessment, they are assessed on health inequality. So being able to identify it and taking steps to address it. However, it's very hard to do so if you actually don't know what you're looking for. So I then asked, well, how do you identify, what are the triggers for you that would make you look and say, is a health inequality happening here in practice? And I got a really curious response that said, and this person said, oh, it's only about age because people only consider older people. They don't care about younger people. It's not about young people, it's all about age. Older people get it all. So in trying to challenge like their bias and why they're thinking like that, it always came back to, well, I don't see it, no one's complained about it, it doesn't affect me. So I spoke to one of my colleagues and I asked her the same questions, and does she see it in practice and what will she do? And would she be comfortable in challenging it? And her response was, no, I don't see it. I think everyone has equal opportunity. Everyone that accesses our service has had the same opportunity. And so I said, so do you not consider their journey into it? And she said, no, not really, because once they're here, everyone has the same opportunity. And I said, well, what about after? She said, no. She said, even in the acute setting, if we are discharging a patient, if a 40-year-old white woman needs carers, and there's an 86-year-old who we called Doris, who is from the Caribbean who needs carers, they're both going to get carers. So I said, so the disparity in age, would that not be a thing for you to look at? Maybe Doris has been waiting 20 years for help. She said, no, because at this point, everyone is equal. And I said, well, what about after? Well, no, it doesn't matter because everyone is equal. And so I was really curious as to what it is that we see as a health inequality, what are we looking for and how do we address it? So if we are not aware of it, then we can't really address it. I then spoke to a clinical educator and I said, well, how are you able to kind of mark students on this part of the assessment form? And she said, oh, I just send them away and I ask them to bring back evidence. I said, what type of evidence? Oh, just something written to say that they understand what health inequality is. So I said, so what do you understand about health inequality? Oh, it's just about money. I said, so do you see it in practice? She said, no, not really. So I pushed a bit further and she said, well, maybe I don't see it as much as I could. She said, to be honest, I'm a middle class, white, straight female. It doesn't affect me. So maybe I'm not seeing it because I don't want to see it. I said, would you challenge it? And most of the responses across all the people I spoke to was no, because if I challenge it, I'm calling somebody racist. And I said, well, you're not saying that they're racist. But what you're doing is you're trying to create a fair and equal system. However, it's very difficult for them to then kind of push further, because everyone, if you always see everyone as being equal, and that if we're at this point in time, we're at the same place, no one's really counting what happened before, or no one's really paying attention to what's happening after. So in the borough that I work, which I worked with Arnie, lovely Arnie, for a long time, because my colleagues had said that they hadn't seen it in practice, and I know that I've seen it many times, multiple times, I decided to just kind of have a look at what was going on in the borough of Wandsworth. So I'm going to give you a little bit of data, and I hope I don't bore you, so please stay with me. So within the borough of Wandsworth, 67.8% of the population are white, 11.7% are Asian, and 10.7% identify as Black. Wandsworth is somewhere in the middle when it comes to, on a scale of who are the most deprived boroughs to those that are less deprived. So they sit somewhere in the middle. Okay, and the data for their life expectancies, which we kind of use to measure health inequalities, is as follows. So life expectancies for males at 65 years is 19.1 years, which is 0.7% higher than the England average, but it's 3% lower than the London average, okay? And for females, life expectancy at 65 is 21.8 years, which is 2.5% higher than the English average and 2.2% lower than the London average. So I then looked at which was the most deprived borough in London, and the most deprived borough is Tower Hamlets. And when I looked at their figures, it was really, really quite shocking. So life expectancy at one point was 55 years for males in Tower Hamlet. At the moment, it's 60.5 and 65.3 for males and females respectively. So I then looked at the ethnic disparity of Tower Hamlets. And in Tower Hamlets, the rate of Asian community is 68%, and then the other ethnicities make up the rest of that borough. And so what I'm trying to say is that I'm not saying it's just about race, and it isn't just about race, and we need to be really clear on that. It's about the socially excluded groups such as homeless people. It's about people who have low education. It's about even children who have been bullied. It's a very complex kind of topic, health inequalities. But we teach it and we push it and we shout about it. However, it's how it's landing with people and how do students understand it, who are then going to be the next generation of qualified staff. And in fact, how do qualified staff understand it if they're going out there and they're seeing this in practice, however, either are not aware of it, or they see it but do not feel confident enough to challenge it. So I know I've only got 10 minutes. So my takeaway message is that as complex as this situation is that yes, change needs to happen. Arnie's doing some great work there. However, it's all of our responsibility to be able to challenge it, to call it out, and actually just to educate and make others aware of when it's happening and how it's happening. So thank you for your time. I think I've kept within my 10 minutes. Any questions I'll answer at the end. And I'll now hand over to Banu.
I think you're muted, Banu.
Now?
Yes.
Yes. I was telling the group earlier that I bought this new headset for a different lecture. Can I get it working? No. Anyway, let's see if I can get the screen share on. We have. Okay. So good evening, everyone. my look is going to be very much more, you know, what do we do as clinicians? I've been working with the older population for over 30 years now. And for people who don't know, my favorite field is Parkinson's, partly because when I started, those were the older age group and they let me chat a lot. So I think that's the way it worked then. So I'm now going to set my timer because I do chat a lot. So I want us to think about one of the reasons I've chosen Parkinson's is because we've got a hugely increasing, it's the fastest growing condition across the world. And in the UK, we are experiencing differences in the people who are migrating into the UK, whether it's because of conflict, whether it's because of family, whether it's because there's workability. So for whatever reason, we are going to come across newer and more different people than from mainland Europe that we used to see 10, 15, 20 years ago. So this is an increasingly diverse population of people. So I needed us to be thinking about that. And when I see people of different ethnicities, they're asking the same question that everyone is asking. They want to know a little bit about the condition, in this case, Parkinson's. How is it managed? What are the common changes? So for us as physiotherapists, we're always dealing with movement. For Parkinson's, there's a good push and into many of the other conditions about exercise and how that fits in, and therefore also lifestyle. So where's the impact of diet? Particularly when I say timing, that's because of medication with Parkinson's. Food types will change and how a person might then stay well and active. So they want to live life to the full, basically. Our issue, however, is we don't know much about the different ethnic minorities. And when we look at the research into Parkinson's, if it talks about the ethnic minorities, it's really talking mainly about the Black group, whether they're African Caribbean heritage, otherwise South Asian. And South Asian can be anything from Pakistan, Bangladesh, Kashmir into India. For some papers, they will actually include people from further east. So there's a real mix in the diversity. And when you actually ask people from the different cultures, I don't think they'd see themselves as the same as one another. So again, it's something to think of when you look at someone clinically. I think it's important. One of the things that Arnie pointed out was this pre-Parkinson's risk rate is very much higher in the migrant population, particularly things like type 2 diabetes, heart disease, the inflammatory bowel disorders. Yet what we recognize is that the rates of diagnosis are lower. Now, it's important for us to think about this just because they're now coming up with a newer theory within Parkinson's that it's gut first versus brain first Parkinson's. So if you've got things that you can impact with or give information that's more about diet, that's more about lifestyle, rather than what's continually happening in the brain, you're able to manage differently. So that's just something to think about. There was a paper where Ray Chowdhury's group went round different areas of London because that's the area they're based. And they actually went knocking on doors to find out from people the possible subtype of Parkinsonism. So for people who aren't that familiar with Parkinson's or Parkinsonism, you can have people with a more idiopathic cause. So we don't quite know, but at least they usually respond well to medication, to exercise, whereas there's a Parkinsonism, they used to be the Parkinson's Plus, advanced Parkinson's, different names to them, but they don't always respond as well, and they're very much likely to have a shorter lifespan and less life quality aspect to them. And what they were finding in this paper is that in people who are of Black, African, Caribbean and South Asian origin, they had a higher rate of Parkinsonism. They also noticed that their non-motor symptoms were more prevalent than the motor. So although they all had movement issues, because you can't be diagnosed without that, things like anxiety, depression, bladder issues, sleep problems, they were all higher prevalence than in a white population. There are people always asking, particularly when they're from different ethnic groups, about, well, what's the risk to the, the generations upcoming? And some people don't want a diagnosis based on what they might hear. It does affect standing in communities. It does affect marriage. It, proposals into the future. But we're also coming across the whole issue when you're the older generation, when you've come into a new country, they're starting to understand the Western medicine, this diagnosis of one condition and symptomatic treatment, whereas they often combine it with what local healers, what their cultural medicine styles might be. So for me, I know in South Asia, it would be Ayurvedic, it would be Unani alternatives. So far more around the medicines from natural, herbal, natural healing, different types of spiritual. So it is different to just going, consultation, diagnosis, medication, off you go, we'll review you when. So it's people are coming to terms with the differences in the type of way they're dealt with. If we're thinking then about movement, when I'm talking to people of different backgrounds, you tend to find that if you've got Black African, Caribbean backgrounds, the likelihood is people have much more experience of the slowness of movement, bradykinesia. There's this issue about the memory problems, cognitive impairment, which again has been touched on. And this is compared to other ethnic groups and the white populations. It's thought that people from Asian backgrounds, they're more likely to freeze and experience dyskinesias. And there's been a lot of discussion about that because these are people who don't regularly come forward for research trials. So a lot of the discussion might be from research that's into people, particularly in a different country at the time, and then they extrapolate the data. There are inferences made in comparison to the UK, and sometimes they are from UK back data and qualitative material. So it's sometimes quite hard to understand how likely this is. There's also the large discussion on tonal differences. So you have people of more, the Black origins tend to have a higher background muscular tone compared to, for example, people from Asian backgrounds who have wonderfully weedy legs and arms, but they have a nice rotund middle if they're left to their own devices. So the differences then we see in movement patterns, make them susceptible, particularly to increased risk falls. But then, as Arnie pointed out, we don't see people with different populations in our falls classes, in our groups. And it's hard if we're saying that this group or the ethnic groups have more Parkinsonism, just because there are harder, Parkinsonism is harder to deal with than idiopathic Parkinson's. So we need to be thinking about what those background weaknesses are. When we think about diet and food timing, there's been a lot of information looked at as people over 2, maybe 3 generations transition from whatever was a homeland diet to a far more westernized kind of diet. So we need to be thinking about that. And for me, with Parkinson's, particularly protein intake and how that times with medication, because you shouldn't have the two at the same time. And if I just think about my recent trips to see my mum in India, my breakfasts were very protein filled compared to here, when I might not have much in terms of, milk. I'll have water with porridge, and, the protein intake is very much less. There's food intolerances as people are getting used to a different diet types. So again, how people absorb medication, how it's then distributed across the body, how it disseminates and how it's then eliminated, means that you find that quite a few medications are just less effective. So this is why sometimes there's poor management of any of the conditions that people have, particularly heart disease. Now they're finding out that the levodopa replacements aren't so effective for people with Parkinson's. And you've then got to take into account that different people will fast. So I come from a Hindu background, and we have something called Ekadashi. So every fortnight there's a fasting pattern. It's different to currently there's Ramadan going on. So that's again a completely different fasting pattern. So it's whether we know what the changes are in the different populations. I then wanted to just touch on the fact that staying well and active is harder when you don't know the people you're going to join in with. It's like going to school the first day or going into new work. We need to educate ourselves, and we need to understand that although people themselves need education about their condition, I would say a westernized approach of therapists or health professionals to an older generation is we treat them with a familiarity that they may not have experienced back home. It's seen as quite an aggressive approach, that a youngster is just approaching an elder, and it doesn't always go down well. So people won't often seek help. They sometimes don't trust what's happening. So there's a difference in barriers as to why people won't access information, don't take the responsibilities in the same way that we might expect of a white population. And in the green, I've just suggested some of the ways that we might approach people. Just sort of the difference in working hours might be the more higher intensity bursts of exercise, shorter sessions, maybe exercise snacks to fit them in between work or as they are working. And then we've got to think about when someone is from a hot country, exercise is not what they're going to think of going to the gym for a lot of people, unless they're from a richer, a different stylized background. But what we're finding that we notice a lot different is the children who are of mixed race couples are taking this very differently. So the future research is going to be very interesting to see. I would suggest that we make sure we check what's available locally, because what I'm seeing in Sheffield particularly, and I know it happened in London, a lot of the gurdwaras were having they've got gym areas and they're just open to all. They feed people, they have exercise session. So these are in the Sikh temples. But also you've got to try and look at what's available locally in terms of things like swimming, other sport. Are there women only sessions for people who don't feel comfortable or would not be looked on well should they join mixed groups? So I'm going to stop my share and just say, it's just a very quick whistle-stop tour into things we might be thinking of into different conditions, but for me, obviously, Parkinson's.
Arnie, Wendy and Barney, thank you so much for being so generous with sharing all your experience and knowledge with us all. I mean, certainly you've given us all a really broad oversight of health inequalities in older people, combining that with some true evidence-based practice. So thank you. At this point, I would like to open up for any questions. Please do raise your hand or just come in if you have any questions in particular.
I'm going to answer Christine's question. There are, especially since the pandemic, there are quite a few different groups set up who will deliver specific community foods to different people. So I've got an aunt who's in Kingsbury down in London, and she gets idlis, dosas, all frozen foods delivered in the same way that Wiltshire Farm Foods do. So you get very different groups of, there are companies now delivering specific foods for people.
That's great. Thanks for that, Banu. Whilst people are having a think of questions, we just had 2 questions from the chat. So it's mainly for Arnie. So from Adrian, with the rates of dementia, is this linked to the rates of cardiovascular dementia, and can the data differentiate between vascular dementia and Alzheimer's dementia? And Dave, on a similar note, asking, why is there a difference in the dementia rates?
Yeah, thanks for those questions. So I suppose, I mean, I'm not an expert in dementia health inequalities. This is a piece of work that's going on within our organisation. So just to be honest about kind of how much I know about this topic, but I would say there probably is that link between cardiovascular disease and vascular dementia. But also when we think about dementia as also, it's a neurological condition, but it's also a mental health condition. And so thinking about people's experiences and the kind of weathering effect potentially of racism, there have been some hypotheses around that. So yeah, the reasons behind it are kind of there's not hard evidence behind it. And that's why more research is kind of needed within that field. And I think it'd be really interesting to kind of look at dementia in other countries, in terms of if we looked at India or Africa and looked at those cohorts and their research to kind of find out what their kind of rates were like in comparison to the UK. I think that'd be really interesting to kind of see what the differences could potentially be. I'm not sure that answers the question, probably just gives more questions.
Thank you, Arnie. Any more questions external to the chat? Or Arnie, sorry to bombard you with one question after another. In your discussion points, you talked about engaging the public in the research that you're doing, and I'm interested to know whether you found sort of an optimal way of engaging the public and those that have lived experience.
Yeah, I suppose it depends what you're trying to do. So if you're trying to conduct some research because you think it's the right thing to research, then that probably isn't the right way of going about it. So it's about trying to have those real genuine connections with the local community to be able to find out actually what's important to those individuals, what's important to those communities, what are the things that they care about, and then that in a way should help to generate those questions that are coming up. So for us as an organisation, we have various stakeholder groups, but also kind of within that, we ask people to kind of go out and speak to people, speak to real people. So we link with some really good charities like the Caribbean and African Heritage Network. And I predominantly work in maternity and neonatal, so organisations like 5 Times More, Black Motherhood Group. So actually speaking to real people and finding out what's needed and then trying to co-produce that, but not just in a kind of tokenistic, we've done some work and we've taken it and we've asked them to approve it, because that isn't co-production, but actually doing it from a really genuine point of view and valuing that. So paying people for their time, you know, not just a £5 Amazon gift voucher, but, you know, actually paying properly a decent kind of wage in a way, but also doesn't have to just be financial. So in terms of upskilling people, providing resources, networking opportunities, there are lots of ways that you can kind of reimburse people for their time and their knowledge and their skills. But yeah, I think it's something that often within the hospital setting, and I know, you know, when I worked clinically, when you go to kind of patient groups, the people who come forward, the people that put themselves forward to patient user groups, they're all white middle class women, middle-aged or older, like to sort of, you know, really generalize, but it's kind of people that have got the time and they're happy to advocate for themselves, but they're the people that then design the services in effect. So what we need to do is actually go out into those communities and find out what would work for those people. So a good kind of starting point is to kind of look at your demographic and go, okay, is our this is the first thing you should do is like look at your service, look at your data, and look at your population, your local ONS data, and go, does it match? If it doesn't match, then you've got a problem. My challenge would be, you know, I doubt it does match. So trying to make sure what's the reason behind that, talking to your manager if you are the manager, thinking about, okay, how do we do this differently? And now all of the places you work will fall under a different ICB, the Integrated Care Board, and they have health inequalities within their jurisdiction, and it's actually a legal requirement that they, you know, make changes and deliver on that. So with that knowledge, go forth and question people with kind of conviction that they have a responsibility to be doing this. It's not just a nice thing to do. This is a legal responsibility, and it's a patient safety issue as well. If patients are getting poor access, poor treatment, poor outcomes, then they're not safe. Sorry, I've kind of gone off on a tangent, but yeah, sorry, stop talking.
No, it's brilliant, and some really, really useful pointers there that hopefully we can all very much move forwards with. Did I see a question come up in the chat, Sue?
Yeah, this is from Mel to the presenters. I'm just going to read out the question. Given that we're all individuals or health needs or requirements, what extent should we stop using group labels such as BAME?
Yeah, I completely agree with that, Mal. And some of the data that I shared was from the Alzheimer's Society website, which is why I kind of use that terminology. But as an organization, we don't use the word BAME. And we did a kind of research piece to ask people what terminology should we use. And they said to be as specific as possible, which is what we kind of try and do when we're looking at this work, so that we're actually not lumping all people who aren't white together, because we're not all the same. And even when we talk about a Black population, like there's differences within that, and South Asian, like Barney said, there's so many different parts of South Asia. So yeah, I completely agree with you. We shouldn't be lumping everybody together in that one sense.
Thank you, Arnie. And Barney, you've got your hand up.
That's if I can you hear me? Yes. Again, I agree. And I really do hope that when we see individual people, we take that into account. And I was just reading a couple of Christine's points in the chat. And, you know, that proves that, yes, there are difficulties, but she is seeing people as they are in their living circumstances, trying to get the most out of people. It's a very difficult one, because I think when people, as Arnie said right at the beginning, and then, you know, Wendy reiterated, when people aren't so well or used to speaking out for themselves, they want others around them, or they're used to having their family around them. So treatment sometimes is with the family around them. And although it can, you know, there are issues when we talk about translators or not. And sometimes you wonder, is the family actually translating what I've asked or not? You know, that's currently the best way to actually gain the trust of the person, actually be there with them in their environment. And I think that's the way in with quite a few people, rather than expect them to keep coming to clinic if clinic is somewhere they just wouldn't normally come to. They just won't attend. So we do have to find ways, whether we go into local communities, whether we go do home visits, whether we meet someone in a park, you know, we have to find ways to make someone more comfortable so they will access what we're offering. And I think as physiotherapists, we're good at that. We're very versatile. It's just the older people don't like the cold. That's the only thing. Winter.
Thanks for that, Barney. And I guess, like you say, spending the time to build that kind of therapeutic relationship and understand what's important to them to then guide our treatment, isn't it? And I like your term, that exercise snacking. So I guess like some people with social responsibilities, it's rather than we need to do these exercises 4 times a day, it's how we adjust things within the responsibilities. Thank you.
I'm just looking at my clock and I see that 8:30 has arrived. So unless anyone has any burning questions, I will hand over to Simone to draw us to a close.
Yeah, thank you ever so much, everybody. It's been really interesting to hear about all the different perspectives, and I think I've certainly taken things away. And I'm going to challenge my colleagues about health inequalities, like what Wendy suggested as well. But thank you ever so much. So yeah, so this is the end of the webinar. So once the webinar's finished, you will receive a an evaluation form, and then once you've completed the evaluation form, you will get a certificate for attending the webinar. The recording will also become available, and I'm sure we will put the link into social media that you can access that. And I think it might come out on an email as well. But yeah, thank you ever so much, and have a good evening.
While they're all going, thank you, girls, for asking us to be part of this. See you again.
Thanks, Barney.
Thank you.
Thank you.
Great.